Welcome back, listeners, to Drug Diversion Insights. My guest today is Dr. Paul Lynch. Dr. Lynch is the co-founder and CEO of US Pain Care. Welcome, Paul.
Thank you very much. I appreciate you having me today.
Absolutely. So you're an anesthesiologist, which obviously goes nicely hand in hand with pain management. Share a bit about your journey and why you started US Pain Care.
Sure. Well, thanks for having me on today. I'm very passionate about helping people who are suffering with chronic pain, but I'm also passionate about helping people who have mental health conditions and substance abuse disorders. And I've spent almost 20 years now as a pain management doctor here in Phoenix, Arizona. I like to tell people when I'm telling my story, I didn't always know that I was going to be a pain doctor. My dad was a therapist. He was a licensed clinical social worker, and I wanted to be like my dad. I wanted to be a psychiatrist, because I wanted to be a medical doctor, but I wanted to be in the psych space. When my dad was a counselor back in Louisville, Kentucky, I bet it was about 1985. I was 9 years old, and my dad got a phone call from a patient that was suicidal, and she was going to kill herself. And he wrote down on a piece of paper to go next door and call 911 and to send the police to the address that he had on the sticky note. And I'm literally like 9 years old. And so
Yeah.
I feel like this like superhero. I run next
Yeah.
door, I knock on the door, we call 911. And my dad kept the patient on the phone. And he told me later that we saved her life, that the police got there and were able to take her into a facility. And ultimately, she didn't kill herself and she survived. And I felt like at 9 years old, like I was like a superhero, like I
For
had
sure.
saved a life. And it was like,
Yeah.
to mix the metaphors a little bit, because we're going to talk about addiction. I talk about I've been chasing the dragon of saving lives since I was 9 years old.
Mhm.
And for most of my life up until 26 years of age, I wanted to be a psychiatrist. So I went to college and I was a psychology major. They told me I should be like biology or chemistry or something. And I said,
Mhm.
I'm just really fascinated with the human mind and I want to be a psychiatrist. And they were like, that's a bad idea if you want to go to medical school. It's funny, today they're starting to encourage more degrees
Yeah.
like psychology before medical
Yeah.
school. But back then, my counselors told me I was crazy. But I was pre-med psychology, and then I did get into medical school. They told me during my interviews not to tell them that I wanted to be a psychiatrist because they might think I was crazy, or they might, most people don't become psychiatrists. So you typically would have a primary care doctor interviewing you, and you should tell them, oh, you're not
Yeah.
sure yet, but you definitely like primary care. I was like, well,
Yeah.
that's just a lie. I want to help patients
Yeah.
with mental suffering. Like that was my
Yeah.
calling. And so all the way through, I was very consistent from the age of 9 till about 26, so 17 years, that I wanted to be a psychiatrist. I matched in psychiatry and had a residency set in the city. It was like my dream job. And
Mhm.
about a month before I graduated medical school, 24 years ago, my mother-in-law was diagnosed with cancer. And the family asked me to go to the hospital and help with her pain control. And I really learned a lot about pain during, that month. She had a
Mhm.
rapidly progressive form of pancreatic cancer, and she had 7 fractures in her spine. And so when they would move her onto the table to get treatment or an X-ray or
Mm.
whatever, she would cry in pain. She was hurting so much. So they would had to give her so much medicine that she was basically asleep. And I was researching different treatment options, and I found out a couple things we could do to help her, including there was this procedure called a kyphoplasty, which is if there's a fracture in the vertebral body, it will collapse. They call that a compression fracture because it compresses in the spine, and you can actually put a needle in it and blow a balloon up, restore the height to the bone, and then put cement in it, and it takes away the pain.
Mm.
And when I read about that, first of all, my mother-in-law needed that, and it was like this hope that we could take away the pain and suffering. Um, when I read about it, I thought it was the coolest thing I'd ever seen in my life, and I decided to drop out of psychiatry and become a pain doctor. Now, again, many of my colleagues have told me, you could have just been a psychiatrist and been a pain doctor, which is true, especially today. Um, there's less and less anesthesiologists actually going into pain. And
Hmm.
so there's been a lot of psychiatrists that have gone into the space, which I love because I think that psychiatrists understand suffering better sometimes than an anesthesiologist or a physical medicine and rehab doc, or at least they have a different understanding. And I think
Sure.
that they have a lot to offer to our space. But if you go back to my story, they told me to be a pain doctor, I needed to be an anesthesiologist. And so I went to the dean of my school and told him I was going to drop out. And he's like, "This is crazy. You wanted to be a psychiatrist your whole life." And I said, "I
Yeah.
know, but as a pain doctor, I can help people with mental suffering, but I can also help them with physical suffering." And
Mhm.
so I did. I dropped out of a psych and I became a anesthesiologist, which is a story, for another day. But and I know this is a long opening, but I would just
That's
say
good.
to give fairness to the story, um, I had what I call about a 4-month honeymoon with the pain management space. I mean, it was 2002. It was kind of the height of the opioid prescribing era. We had all these medications that, um, we believed were like the best opioid pain medicines that had ever been made that, didn't have as many side effects. We were being told that there was less addiction. I was at Beth Israel Medical Center in New York City, and one of my teachers was a guy named Russell Portnoy, who was like one of the first people ever to do research showing that patients
Mhm.
who didn't have cancer might benefit from pain pills. And so I was there in New York, really at the beginning of when we were writing a lot of opioids. And I like to tell people I had about a 4-month honeymoon period, and then in the fall of my intern years, I was doing general surgery in New York City because I wanted to be an anesthesiologist, but I wanted to start with a surgical background so that I could do these more advanced surgeries for patients. And about 4 months into my internship, in around October of 2002, my brother had come to stay with me, was doing research, and he went into the bathroom and locked himself in the bathroom. And we couldn't get in, and we didn't hear for him, and he wasn't talking, and we had to break the door down. And he had a needle in his arm. It was heroin, and he wasn't breathing, and he was like had overdosed. And so we kind of resuscitated him, and I talked to him and helped him get into treatment. But it was the first experience I'd ever had with that, and it was my
Wow.
own brother. I wasn't aware that my brother had a problem with opioids, and it set off, unfortunately, what was a 10-year period of my life, a full decade, where he was addicted to opioids. And so, kind of ironically, during the time that I was an anesthesiologist and learning about these medications and what's fentanyl and what's an opioid, and before I became a pain doctor, I was an anesthesiologist. So I'm in the OR and I'm using these medications. My brother was, at times homeless on the streets in New York
Yeah.
City, addicted to the very drugs we were using therapeutically in the hospital. He was addicted to them, and I think it was a very stressful, scary time in my life trying to help my brother. But the silver lining is I learned a lot that I've been able to help in my career as a doctor.
Right. Yeah. Yeah. That's a lot of different things. Seeing your father help people through therapy and being involved in that first incident and getting all of the psychology background. It's funny, I went to school getting a psychology degree and thought, oh, I'll go to
Did
med
you?
school then. Yeah. But then I
Really?
started freaking out. Like, what if I don't get into med school? I don't want to just, what am I going to do with a psychology degree? Because that's not what I wanted to do.
That's
And
what they
so then
said to
I
me.
pivoted. Yeah. Yeah. So then I pivoted. I actually had a roommate at the time that was in pharmacy school. And I'm like, well, what do I do? And she's like, well, you need to apply. Like right now is the time to apply. You're at that stage. And I'm like, well, what do pharmacists do? So that was the beginning of my career, which was not very well thought out, but ended up
Huh.
being perfect for me.
Yeah.
But yeah, you had a lot of things kind of come together that really shaped your passion and what you think of how you think about things. Definitely.
Yeah, I mean, people who hang around me, I talk about God a lot. I can't help it. And I think God does things for a reason.
Oh, for
And
sure. Yeah.
whether it was at a very young age, honestly, I think I wanted to save more lives at age 9. Like I was like, that's what I want to
Yeah.
do. I want to save
Yeah.
lives. And so to have that instilled in me at 9, and then to look at my dad, who we could do a whole podcast on my dad, but he's this amazing therapist that spent most of his career on addiction and pain and substance abuse, and like he's the
Mhm.
perfect addition to our clinics. He's I don't want to call him almost 80 because he's probably watching this, but he's in his 70s. And
Yeah.
to this day, he still helps us in our clinics. He still does
Oh.
therapy with patients. He works with the homeless. Like he has this big heart for people. And
Mhm.
so I feel like I've done like an internship or residency under
Sure.
my dad to teach me um, the behavioral health side of pain. And
Yeah.
then going through my training with my brother was like my addiction training. And then,
Mhm.
of course, I'm an anesthesiologist and I'm fellowship trained in pain. And so I went to one of the top fellowships in the country and trained under one of the premier pain doctors who really created our space. It was a guy named Gabor Rotz, and he passed away last year. But he was literally like one of the first pain doctors in America, and he was one of the guys that taught me. So between my dad teaching me mental health and my brother treating me addiction and Dr. Rox treating me pain,
Yeah.
I feel like I'm very well suited to
Right.
kind of lead this movement of we think we can do a better job of treating pain.
Right. Yeah. The big picture piece of it. Well, part of mitigating drug diversion is moving that discussion all the way upstream, right? Is exposing people to these pain meds. That's certainly part of it, and how to minimize that exposure. I read the description of your US Pain Care on LinkedIn, and it says that it's dedicated to revolutionizing chronic pain treatment through a holistic approach that prioritizes conservative care, mental health integration, and addressing substance use disorders. Now, we all know all cases are different, right? But overall, what does that look like in your pain clinic? What makes it different?
Yeah, it's a great question. I think when I talk about holistic care, we believe that preventative care on the front end is the very best thing we can do. And so that means when someone, so for example, I do a lot of personal injury work, and with U.S. Pain Care, some of the patients we see is they get in an accident and they don't have any insurance, and so it's really an opportunity for us to say this is the standard of care. And I would say that if it's my family member and I'm not dealing with like the insurance saying yes or no or whatever, if I had someone get in a car wreck, I would say, well, I would start with, massage, right? Your neck hurts, like get a massage,
Mhm. Yeah.
physical therapy. I'm a big believer in chiropractic care, exercise, diet, supplements, like looking at what you're eating and thinking about food as a medicine, just keeping active, weight loss, trying to find what I tell my patients is your ideal body weight. Like,
Mhm.
and then talking to every single patient about the importance of the mental aspect of pain. And this is where, if I'm talking to a patient, sometimes patients get a defensive. By the way, not as much in 2026, but in 2007, when I started, when I would
Mm.
talk about the mental approach to pain, they would say, I'm not crazy. I'm not crazy. And I would say, I know, I'm not
Mm.
saying you're crazy. And they'll say, well,
Yeah.
it's not all in my head. And I would say, no, I
Mm.
know it's not all in your head. What I'm telling you is, um, if any person if you had them have 10 out of 10 pain, how long would it take before they develop depression or
Sure.
anxiety or
Yeah.
suicidal ideation? And I've asked that question to a lot of people, but like really, if you were truly going through 10 out of 10 pain, a couple years ago, I've never had suffering that's 10 out of 10. I just have not. But a couple years ago, I had a couple bouts of hiccups that lasted like 7 days, right? And so,
Hiccups?
yes,
Wow.
7 days, and the doctors couldn't figure it out, and there's no medications that would work. And I started reading these case reports of some people that would like hiccup for like 20 years,
That's
and
horrible.
like I wouldn't sleep at night, and I would say that I was truly suffering. And
Yeah.
after about day like 5 or 6, I started thinking like, how long could I go on like this, where I would just ask the
Right.
doctor to like put me out of my
Shoot me.
suffering. I don't want to live,
That's
right?
right.
Like,
Yeah.
does that make sense? And so I think of that with the pain patient is someone who's really suffering that much. How long can they suffer 10 out of 10 pain before they start to develop a mental health
Right.
condition like depression or anxiety or suicidal ideation? And so I would say that in my clinics, I refer personally when I see a patient, I refer close to 100% to see like a licensed clinical social worker or a counselor or someone that can talk to them about the mental aspect of pain. And I think the entire system is starting to catch up with that. So when you ask me what's different, I start with like this holistic physical approach where we make our bodies as healthy as we can. And then
Hmm.
I try to move to a mental approach of like, is someone talking to you about your pain, like, and your suffering, and how are you doing with it? And are you depressed? If so, are you being treated? And is it successful? A lot of people have depression. They get on a med, and that's it. They don't ever talk to a doctor again. But they're not actually better. They're still
Hmm.
depressed. And
Right.
so, are you successfully treated? So I focus first and foremost on a holistic approach to health, and then the mental approach, and then of course cutting edge pain. Like we recruit some of the best pain doctors in the country that may have been surgeons before. We have, doctors that were orthopedic surgeons or neurosurgeons or what I call pain surgeons, like myself. I did a year of surgical training, and then I did 3 years of anesthesia and then a year of pain. So I did 5 years of training. And someone like that that's done all these procedures, and you combine that with a holistic approach and focusing on the mental and then these cutting edge treatments. And then I would say the final aspect that differentiates US pain that makes us better for a lot of patients is we will use opioids. We do use opioids across the board. I believe that opioids for the right patient, is appropriate. Um, but if the patient becomes addicted, we call that opioid use disorder. A lot of clinics will kick them out and act like they've done something wrong. They violated the policy, whatever, you got
Mm.
to leave. I would call opioid use disorder a known side effect of writing opioids. And so if you're going to pick up the pen and write a script for opioids, I believe, and many, many thought leaders around the country agree with me, you should treat the addiction. If you gave someone morphine and they got constipation, we would all treat their constipation, with stool
Sure.
softeners. If they have itching, we would give them Benadryl. I mean, you're a pharmacist, so we would treat the addiction. But I'm sorry, we would treat the itching. But for many
Sure.
years, we had rules that if you wanted to treat addiction, you had to get a special license and special training, and we
Mhm.
acted like
Mhm.
addiction was different. And that went away, as you know, about 3 years ago. We dropped the special requirement for treating addiction. And today, I believe the standard of care in the country should be if you're going to write opioids and the patient gets, opioid use disorder or a substance abuse disorder, you should treat that addiction. And that's what we treat. Or that's what we teach at US Pain Care. And so the combination of holistic, physical medicine, really focusing on mental health, the most cutting edge pain treatments in the country, and then recognizing addiction and treating it when we see it, I think differentiates us as the best pain group in the country.
Okay, so somebody could come into US Pain Care and for the first however long, not even receive any pain meds because you've got them working on some of these other things.
Oh, for sure. Yeah, I
Okay.
mean, the whole country since about 2013 or 14, most of the country has realized that we've probably been over prescribing opioids.
Yeah.
And so most doctors are writing less and less. I've been teaching to get patients, off of opioids for years. However, there are a lot of patients that need opioids. So it's this balance. When people come into
Sure.
us, we definitely don't just jump straight to opioids. We try everything we can. We try non-opioid medications. We try physical therapy and chiropractic and massage and a lot of things I talked about earlier. There's all these medications we can use, from medicines that treat the nerves to medicines that treat the muscles to anti-inflammatories. We have cutting edge procedures. Like we try to delay the opioid conversation as long as we can.
Hmm.
But the flip side is, again, these patients that have, we have patients in our clinic that have true suffering, that have had
Sure.
multiple spine surgeries, that are paralyzed, that have cancers that will eat away their faces. Like we have crazy suffering. And when we see that, we appropriately use opioids when necessary.
Right. Yeah, of course. They do have their place. What is the difference between somebody that we would say clearly has a substance use disorder where, their whole day revolves around where am I going to get my next dose, and the person that has chronic pain and is on opioids and obviously is physically addicted. They've just been on it for years, but they don't spend their whole day thinking about where, how, and where am I, and I'll do anything to get that next dose. So, I mean, I would say physical addiction in both cases, but I, it's different
Yeah.
in the way I don't know quite how to explain what I'm asking, but hopefully, like, what is the
Yeah.
difference?
No, it's a great question. We were talking about this a little bit before. And so we don't use the word physical addiction, it's physical dependence, which
Okay.
addiction is. Well, I'll start with dependence. Physical dependence means if you take these medications over time, you have a receptor in your brain called a mu receptor. And, if you're taking Percocet, the Percocet sits in that receptor every single day. And then if it goes away, the receptor will basically fire and you'll go through withdrawal, right? You'll have sweating and anxiety, and you'll have uh, heart rate, tachycardia, an increase in blood pressure. And that withdrawal shows that your body is dependent on it, but that's not addiction. Addiction is when you basically do a set of behaviors that are pathological to the person, like spending all their money, from their paycheck on opioids, or going to the street to get opioids, or taking more than what was written, or crushing it
Mhm.
up and shooting it up, or, these things that are hurting yourself and you're doing it anyways, versus someone who's really hurting and they're seeking pain relief. This was talked about a lot a couple decades ago. This concept of pseudo addiction, and I think it has really relevance to this conversation. There are some patients that are suffering so much that they're seeking pain relief so much that they basically look like they're addicted because they want the medications, but they truly have a real pain complaint, versus someone who becomes addicted to it and starts doing things that are hurting themselves just to get it. And so that's what
Yeah.
we would call addiction.
Sure. And how do you what is, I've heard of trauma load and, what we've all been through. We all handle things a little bit. I could have been through the same thing that somebody else had been through, and I don't go that direction. They go a completely different direction. What is the difference that you find as for somebody that becomes truly dependent versus physical dependence because of the pain?
Well, I think it's funny. I have these conversations with my son, and I think it's great that you're a psychology major, right? Because you're thinking of, like, we can have such a nice conversation. I love it that you were a psychologist who became a pharmacist, and I was a psychologist who became a doctor. Like, we can have just such an interesting conversation about the mind. My son, who is studying psych right now in college, we have these conversations about nature versus nurture. Your
Mhm.
body versus your mind, like your experiences, your parenting. What I would say is there's a very strong nature effect here from the literature. And what that means is if I became addicted to opioids, my sons would be highly likely to also
Sure.
become addicted to opioids. And this has been proven in the literature that there's a strong genetic component, and that's the nature, right? That's like how you were born, like your DNA. And so you
Mhm.
talk about you handle it different, maybe because of your experiences, and that's true, but you also might act differently because of your brain chemistry, right? And the funny thing is, my son, he doesn't believe the nature effect as much, and he
Mm.
focuses. I mean, he's young and he's not a doctor like me, and so I try to teach him and educate him. But
Mhm.
he's learning the psych, and he believes like 80 or 90 or maybe even 100% of how you act is like your nurture, how you were raised, how your parents raised you, your trauma, as you talk about your childhood experiences. And me as a doctor, I try to bring in, well, wait a minute, you
He
can't
wants to be able
overcome.
to blame you if something goes wrong, that's why.
That's it. That's it. You must be a parent. So he talks a lot about nurture. And I, as a doctor, I believe that the answer is probably 50-50. That
Sure.
the way your experiences are different than mine, but your biology is different than
Right.
mine. And at the end
Yeah.
of the day, as clinicians, we need to accept the patient where they're at and realize that for whatever reason, some people, um, here's probably the honest stats, and I've probably spent more time on this than anyone because I'm an expert witness and I've testified in cases, and I'm looking at addiction or whatever. But the real numbers, if you take 100 people and you give them opioids, it's probably about 10% that meet the
Okay.
clinical criteria for opioid use disorder after a certain amount of time. And so, I mean, that's pretty high. Early in my career, like when I first started, like 100% of the patients coming through the door on opioids, they're on very, very high doses. And I think the percentage of patients with opioid use disorder were even higher. But I think the numbers today is probably about 10%.
Okay. Yeah, that's usually the stat I usually throw out, 10 to 15%. But
Yeah.
um, I know you have a foundation, and clearly you're very passionate about this topic and saving lives. So
Yes.
what are your
Yeah.
thoughts on uh, this reducing substance use disorders and related issues and saving lives? How can we do that?
Yeah, thanks for asking. So, I mean, that's really the work of my life, my career is I believe that we can save 1 million lives, and that might seem like a lot or just a gimmick. That's the real number that I believe that we can save over the next 20 years or so, which is probably how much time I have left to kind of run the company or whatever. I think we can save 1 million lives. By a better approach to chronic pain, mental health, and substance abuse. And some patients will have all three of those. And I call that tri-diagnosis. And no one's really paying attention to those patients. A lot of them slip into losing their job and going on disability. Some become homeless. Many ultimately die. The death rate is so much higher on that group. The medical expenditures are probably triple. And so I started. And the pain community, by the way, and I just, if there's anyone watching this from the pain community, sometimes they feel like I'm like really negative on opioids. And the truth is I don't mean to be negative on opioids. I think that there was a period of time that most of us agree we overutilized opioids. And
Mhm.
that was probably from about 1997 to about 2013. If you look over the last 12 years, we've actually reduced our prescriptions of opioids by 52%. I track my data between 2007 and 10. I reduced about 51% of patients I met. I got them completely off opioids. And so I feel like the entire healthcare system has kind of caught up with a lot of what I was
Mhm.
treating or teaching. And I think the pendulum's probably swung far enough on opioids. I think we're actually probably appropriately prescribing opioids in most situations in the country. But where we have not caught up is mental health and addiction. We just are
Mhm.
not doing a good job. If one of my patients comes in and they have pain, I think we do a fairly good job of treating their pain. But if they have pain and depression, I think most of us just aren't doing a great job of really screening for that depression and not just making sure they're on a medication, but is it working? Like, are you actually better? And what we're really doing bad on is the third one is what if they become addicted? A lot of pain patients or pain clinics across the country, I would say a majority, if you become addicted to the medicine, we kick you out of our clinics and make you
Mhm.
feel like there's something wrong with you, as opposed to treating the addiction. And so I started
Mhm.
something called the Treat 'em When You Meet 'em Foundation. And my intent is to, give heavily to this foundation from the profits of U.S. Pain Care. And my goal with the Treat 'em When You Meet 'em Foundation is when someone raises their hand and says, I need help, and you're a pharmacist, so you know that a lot of times when you're deep in the throes of addiction, you're not asking for help. You're not
Mhm.
listening.
Yeah.
You're addicted. But when you ask for help, my teaching with the Treat 'em When You Meet 'em Foundation, wherever you're at in the healthcare system, in a pain clinic, in a primary care clinic, often it's an emergency room. If you ask, maybe you just overdose, right? If you ask for help, that we help you that day. We don't make you wait. We don't make you,
Mhm.
here's a referral.
Yeah.
There's something that I want to start called OCLS, Terry. OCLS. And so you're a pharmacist, you've probably heard of ACLS, which is
Mhm.
Advanced Cardiac Life
Ah.
Support, right? ACLS. So ACLS was launched by the American Heart Association in 1974, and it's been credited with saving over 3 million American
Wow.
lives. The data shows worldwide ACLS, which teaches us, how to bring someone back from a heart attack or,
Mhm. Yeah.
VFib or, whatever.
Yeah. Your little
World,
algorithm.
that's it, the algorithm. Worldwide, we've saved almost 100 million lives, right?
Wow.
100 million. And so I came up with this idea that's going to be supported by the Treat 'em When You Meet 'em Foundation to launch OCLS. So instead of advanced cardiac life support, we have opioid crisis life support. And
Okay.
OCLS is going to teach the system how to treat drug addiction and overdoses substance abuse disorder, opioid use disorder, with algorithms that will save lives. And I believe OCLS
Love
is
it.
going to be a big part of saving the million lives. And I'll give you one example. I've got 8 or 9 initiatives for the Treat 'em When You Meet 'em Foundation,
Mm-hmm.
but one thing that I really want to highlight is this concept of Suboxone microinduction. Are you familiar with that? Have you heard of this before, Terry?
Not micro induction, I don't think, unless they just haven't used the term.
Yeah, I mean, so being a pharmacist, I think you'll understand this more than most, and I try to really kind of, simplify the
Yeah.
pharmacology of it. But Suboxone, which has about 50% reduction in death rate, is the gold standard for opioid use disorder, right? And so if
Mhm.
someone comes in and says, "Hey, I have a problem, I need help," the real gold standard is Suboxone combined with behavioral health. That's been shown to have about
Mhm.
80% success and a 50% reduction in death rate, right? And so we should be using Suboxone, but there's lots of hurdles. One of those hurdles was you had to have a special license until 3 years ago. And so now all Americans, can treat opioid use to, or sorry, all providers in the United States can treat opioid use disorder. But if you now you get into treatment, Suboxone was formulated to treat heroin abuse and not fentanyl. And the reason that's important is because heroin was very hydrophilic. It builds up in the blood, not the fat, and it leaves your system very rapidly, like 18 to 24 hours. It'll be pretty much out of your system. And so the standard of care that kind of developed was if you went to the ER on a Tuesday, and you had overdosed or you were on fentanyl, they would discharge you, give you some phone numbers. People would bring you in and they'd say, well, just stop the heroin for, overnight, 12 hours, 18 hours, show up in the clinic, and we could give you a small dose of Suboxone. And that's called an induction, right? And so that Suboxone induction, you need to wait for the heroin levels to come down in the blood
Mhm.
so that you can give the Suboxone. Because otherwise, if someone has all the receptors full with heroin and you give
Mhm.
Suboxone, Suboxone's 70 times stronger than heroin. So every place where there's like a heroin molecule in a receptor, Suboxone knocks it off, but then the patient goes through rapid, what we call precipitated withdrawal. And so the standard of care kind of developed where you'd send them home, let them go through some withdrawal at home, which I think is crazy, by the way, and inhumane. But anyways, they would send them home. They come back the next day and you get a little dose. You stay for a couple hours, you get a bigger dose, and now you're better. None of that works with fentanyl because fentanyl is lipophilic, highly lipophilic. And so it sticks in the receptor, but it also sticks in your fat all around your body. And if you went home and tried to go through withdrawal on your own, it could take 3 or 4 days, 3 or 4 days to get it out of your system. And I used to tell people if my brother, who was addicted to heroin, could have gone 3 or 4 days without using heroin, he would have done that already. We need a better
Right.
solution. And so the
Right.
solution is what's called a micro induction. And so basically, the smallest FDA approved dose of Suboxone is about 2 milligrams. It's a strip. That's why I'm holding my hands like this. There's a strip of Suboxone. And what we do is we can cut it in half and cut it in half again and give the patient zero point 0.5 milligrams of Suboxone or buprenorphine the very day we meet them, even if they're still on opioids, right? And so I started a starter pack, which I kind of came up with the idea, and I'm going to do it through the Treat 'em When You Meet 'em Foundation. And when I say I came up with the idea, there's lots of doctors around the country doing similar protocols.
Right.
I
Yeah.
came up with the idea to do a starter pack, and hopefully, eventually, we'll give this away for free and we'll do it through donations or whatever. But on day one, you take zero point 0.5 milligrams of the Suboxone, and that's about 4% of the stable dose because most patients are stable in about 12 milligrams. So zero point 0.5 is about 4%. And so what happens is at such a small dose, they don't go into withdrawal, right? It displaces a little bit of the receptors, but not all.
Mhm.
At day
Mhm.
two, you double the dose. You take 1 milligram, and that's about 8% of the final dose. And on day three, you double it again to 2 milligrams. It goes to 16, and so on. And so what you can do is you can titrate on this drug over 7 days. Here's the wild part. The patient could actually keep using if they wanted. They could keep taking the opioid. They could keep taking the Percocet. If they were a street user, they could keep
Yeah.
taking the fentanyl, but we would discourage it. But they could keep using. And then on day 7, once you fully occupy that receptor with buprenorphine, which is the base molecule of Suboxone, they don't really need the opioid anymore. Matter of fact, they lose their cravings. As a matter of fact, if you have a stable dose of buprenorphine, it kind of blocks the receptor and it kind of
Mm-hmm.
tickles it. It gives you a little bit of pain relief. You don't
Mm-hmm.
really, even if you shot up heroin, you wouldn't feel it at the receptor because the receptor is blocked. And so that's a big part of my teaching at the Treat 'em When You Meet 'em Foundation is if we utilize Suboxone with a microinduction, we can slowly titrate it on, and we can do that the moment we meet them and not give them a card to say come back in 90 days or whatever.
Right. Right. Interesting. Yeah. So you just take them from really one to the other, but it's a much safer in the end,
That's it. The
the
moment they
use.
take their
Yeah.
first dose of Suboxone, it becomes safer for them. You
Right.
probably won't save their life with the zero point 0.5 milligrams, but probably anything above 4 or 6 milligrams, it's going to be hard for them to overdose. That's what people don't even realize. When
Right.
you're on a therapeutic dose of Suboxone, it's very difficult to overdose because we've clamped down on the receptor that's responsible for the breathing to stop.
Right. Right. How much pain relief does it provide those that do have pain, real pain?
It's a great question. Probably about 65 to 70%. So we have like this chart that goes like this for opioids, and Suboxone goes up and kind of trails off. So there's what we call a ceiling effect, but it's a pretty good pain relieving medication. It
Mm-hmm.
is an opioid by definition. It's a Schedule 3 drug. That's why we got to be careful with, how we do these programs. But it basically, so the fentanyl molecule will just sit in the receptor. This kind of sits on top, and I say it kind of tickles it. It can't ever completely engage with the receptor, but it can partially tickle it. And that's about a 65% response. But that's good because it also caps the amount of respiratory depression you can have, where you really
Sure.
can't really stop breathing from just buprenorphine alone unless you mixed it with like alcohol or benzodiazepines or something like that. But just the buprenorphine, even if you took fentanyl or whatever, it's very difficult to overdose.
Okay. So this is one of your initiatives to save 1 million lives.
Yeah, I would say that my big initiatives to save 1 million lives are to treat chronic pain better because these
Mm-hmm.
patients, if you don't treat their pain, some can become suicidal.
Sure.
Number two is treating mental health. Again, if we're not treating depression and anxiety and whatever, many of these patients have high mortality rates because they don't want to live, frankly. Three, when they become addiction, treating their addiction. The concept of treat them when you meet them is that we treat immediately. I was going to tell you, if you show up in a hospital system and you have what's called a ST elevation MI or a STEMI, there are rules and guidelines on how fast you have to be
Sure.
in a cath lab. You've probably heard this.
Yep.
And this is all, again,
Mm-hmm.
laid out by the American Heart Association and ACLS. If a patient shows up with a heart attack and a patient shows up with an overdose, do you know that they both have about an 8% chance of dying in the next 12 months? Both
Hmm.
of them have about an 8%. But the patient with a heart attack, we have to treat them within 90 minutes. And the patient with addiction or the overdose, we're okay with 90 days. Like, we don't care.
Yeah. Make an
Um,
appointment. Yeah.
Making a point. 90 minutes
Yeah.
versus 90 days. That means
Right.
that we value the heart 1,440 times more than the mind or
Yeah.
addiction or mental health, right? And so
Right.
I want to normalize treating substance abuse in the ERs, right? The other thing I want to do is I want to work with our anesthesiologists who are prepping patients for surgery and our surgeons across the country. We're doing more surgeries today than we've ever done in the history of our country by far. We're doing so many surgeries. There's a shortage of anesthesiologists like myself because there's so many surgeries happening. And a lot of all the organizations from, SAMHSA to the American Medical Association to the American Society of Anesthesiologists, all these organizations have said if someone's addicted to opioids and they're stable on opioids, you shouldn't, or sorry, they're stable on Suboxone, you shouldn't stop that Suboxone before surgery. But over half of the hospitals in the country will stop it because they just don't know. They don't know that that's the new guidance. And so they'll stop the Suboxone. And now that patient is exposed. They might be addicted to opioids and go out and use. And there's a lot of unnecessary deaths that are occurring because we're taking them off of the Suboxone during surgery. And there's other things we can do in the perioperative space, like regional anesthesia, so we don't have to use a lot of opioids. And
Mhm.
instead of giving them
Mhm.
30-day supply of opioids after surgery or 2 weeks. We're
Mhm.
leaning more towards like 3 to 5 days, and
Right.
education in the community. And so I have all these initiatives that we're doing all around mental health and addiction and chronic pain and opioids. This is kind of my passion, but I believe that if we make these changes as a system, we really
Mhm.
will save 1 million lives.
Right. No, I love it. It's an educational piece and then it's also a stigma piece, I would think, right? Do you think it's about 50-50 or
Yeah, that's exactly right. I'm glad you said that. So I do a lot. We work with NADI together, right? And so NADI is the National Association of Drug Diversion Investigators, and I'm the president of the Arizona chapter. And so I work with police officers, and I work with state regulators, diversion investigators, hospitals, pharmacies, et cetera. And I would say that when I'm talking, a lot of times the things that we are doing, let's say it's outside the standard of care. Have you ever heard of this concept of the science practice gap?
Mm-mm.
So the science practice gap is a fascinating concept that I talk a lot about on these things like addiction and opioid use disorder and Suboxone. The science practice gap is the time period between when it's really clear from the science we should do something and when we actually are doing it as a society takes about 10 years. 10
Mhm.
years, because it takes a while for the new textbooks to come out and the new doctors to come out
Mhm.
and the new chairmans to retire. Like education and the medical system is very ingrained. And so it's
Yeah.
going to take about 10 years. And so it is very, very clear from the data that the stuff I'm talking about is the truth. But a lot of people don't know that. Like I'll go into a room and I always ask the question, I'll say, hey, did you know that you don't need a special license to write Suboxone? And I'll say, how many people honestly didn't know that? And I promise you, it's about half of the room everywhere I go to
Oh, wow.
don't even know that
Yeah.
they're allowed to treat addiction because they were told,
Yeah.
oh, we're not allowed to treat it. You need a special license. And so
Right.
that's part of that's the education piece you say. Then the other half of the room, maybe they knew that they could write it, but they're like, I don't really want to. I think it's the addict's fault. I think that this is their problem. They're being lazy. Like there's this stigma around addiction. And I
Mhm.
don't have the stats in front of me, but it's wild. Like you asked just rank and file people walking down the street, and a majority of them kind of blame the person who's addicted
Sure.
to opioids like it's a moral
Yeah.
failing. And the
Right.
data shows that's just not true. And so education leads to a lowering of stigma, is what I think.
Yeah. Great. All good points. Anything else that you would like to share with the listeners?
Um, I think that we talked a lot about this, but I just kind of want to tie it up in a bow. I talk a lot about tri-diagnosis, but I also I've been telling people there's four patients that have been systematically devalued by the United States healthcare system, and it's because of things like stigma. It's because of they don't have they're not making money for the hospital systems. There's all these different reasons. Like we only have a certain amount of dollars, and the people controlling the narrative, we choose where to spend those dollars, right? And so we tend to spend dollars on heart disease and strokes and surgeries and cancers and things that are kind of hot and sexy to spend our dollars on. But then there's other things that I say we systematically devalue these lives, right? And so number one is pain patients. It's literally the subjective nature of pain. And what I mean
Yeah.
by that is we have objective measurements like my heart rate is 65. And then there's a
Mhm.
subjective component, which is my pain score is 8 out of 10. That number, it's not objective. I don't have a test that says 8 out of 10. The patient's telling me that. By definition, it's subjective. And so I have tried to spend my entire career taking the subjective and making it objective. That's my job as a doctor through my physical exam, through my documentation, through better testing. I try to take this subjective measure of pain and make it objective. But in the meantime, insurance will systematically devalue the pain patient because they can't see it, they can't measure it, they don't want to cover it. Number two is mental health. We've had issues with mental health parity my entire career, before, after. We just don't want to pay for mental health treatment, and I think that's a disservice to society. And I think that ultimately it cost us more dollars in the end by not treating mental health. And then three is certainly addiction, and the stigma with addiction is off the charts, even compared to chronic pain and mental health. We just want these patients to go somewhere else. Everybody hands them a script and says, go down the street, do
Mhm.
this, do that,
Yeah.
but we don't want to deal with the addiction. And then the fourth one, which is probably a little bit beyond the scope of this program, but we're trying to work into some of our clinically integrated networks across the country. The fourth one is actually homelessness. Patients that they don't have a place to sleep, their health expenditures go through the roof. A patient who's homeless can be costing the system between about $50,000 and $200,000 a year, depending on if they have like SMI or significant mental illness. And so if you look at those four, I like to say if you have a pain patient that's been systematically devalued and their pain is not treated, they almost always develop some sort of depression or mental health condition if you don't treat that pain. And then if you don't treat the mental health and you don't treat the pain, eventually some of those patients become addicted. We talk about 10%. But if you take a patient who has a significant mental illness on top of it and untreated pain, it's probably higher than that, maybe 20 or 30%. And then if you take a patient with tri-diagnosis, which is a lot of what I talk about with my career, pain and mental health and addiction, and you still don't treat them, sometimes they can lose their house, they can lose their job, they can lose everything. They even become homeless. And so my teaching is those four lives that have been systematically devalued, we should set up what we call clinically integrated networks across the country where we basically commit that we're going to treat all four of them. We're going to treat the whole person. If they become addicted, we're not going to act like it's a moral failing, but we're going to treat it without judgment, with love, with care. So I think that's the final message that I wanted to say.
Yeah, no, I like it. It's that big picture. It's very complex, very complex. And I like that you're taking that big picture approach. All right. I want to thank you. This is great information. I'm sure the listeners will find it fascinating. And to all you listeners out there, I just encourage you to subscribe. That's kind of how we know that you're still getting value out of this channel. And as long as you get value, then I'll continue to find guests like Dr. Paul Lynch to come and educate us further.
I'm going to subscribe today.
Nice. All right. Thank you very much, Paul.